Hey, everybody, it's Dr. Missy, the nerdy neurologist, here with another episode of Brain Chat, and I am so excited. Today, we are talking about all the pauses: perimenopause, menopause, and what it does to the brain, and how it may affect those living with chronic diseases like multiple sclerosis. And I have an amazing expert with me today, Dr. Riley Bove, who is an associate professor of neurology at UCSF, and she is the expert of all things women and multiple sclerosis. Welcome, Dr. Bove.
Thanks for having me on, Dr. Williams.
Awesome. Okay, so let's get into it. This is a really hot topic, no pun intended with the hot flashes, but this is a really hot topic. People weren't really talking about menopause and perimenopause. It was kind of one of those things that you heard your mom and maybe your auntie and other, more mature ladies that talk about. But now it's something that's really out in the open. I see people talking about it on talk shows. I see lots of doctors, trying to educate the public. So let's talk about how this affects those with neurologic disease. But before we get into that, what is menopause and perimenopause? Let's just start there.
Yeah, it's great to define those terms. So when we're talking about menopause, you have the final menstrual period. That's the final period after which there are no more. And when you have gone a year without periods, you look backwards and say, no periods for a year. That was my last period. That was my menopause. What's actually happening to the body, as you know, is the follicles, start to decrease in number over the course of a woman's reproductive life. And when basically the ovaries run out of the follicles, that's when the periods stop. And there's a lot of body parts, a lot of systems that are involved in menopause. And so, we define it based on the end of the periods, but actually there's a lot of hormonal changes that happen. And in those last few years before the final menstrual period and the first few years after, that's the period. And that's what people are really talking about today. And that is a period of high need for our patients with neurological conditions. And then a few years after that final menstrual period, you say that someone's postmenopausal, and that's the postmenopausal period. And that's yet another thing. And so when we're thinking about neurological conditions, we've got to think about the peri and think about the post.
Mm. It kind of seems unfair, Dr. Bove, because, women want to be done with the periods, and you would think you're done with that. So, yay. But now you got to deal with menopause. And we've got a little guest there. But yeah, so now you got to deal with that. And that kind of sucks. So, when we think about this period of, perimenopause, menopause, and then you said postmenopause, some of the things that are most distressing to people are the symptoms. So let's talk a little bit about some of those symptoms, because I think, as we get a little bit more into this conversation, some of those can overlap a little bit with MS symptoms. And so it becomes confusing. I think we spend a lot of time trying to figure out what symptoms are due to the neurologic disease, what symptoms are due to regular aging, what symptoms are due to all these other things that are going on in the body. So let's break down a little bit some of those symptoms. Maybe let's start with perimenopause.
Great. So during the peri, there are things that women experience. They experience hot flashes.
Mm-hmm.
They experience changes in sleep patterns. Some people just cannot go to sleep, stay asleep anymore. They experience changes in their mood, cognitive fog, decreased libido, and then many other symptoms like bladder symptoms that we can get into in a moment. But when I say those things, difficulties with sleep, difficulties with mood, cognitive fog, energy, those are things that anyone with MS is going to, really resonate with. And so what we're having during the perimenopause is this overlap between the symptoms of MS and the symptoms of perimenopause. And people, one of the three questions I get from patients most commonly during the peri is this my MS? Is this my menopause? Or is it both? And the answer, this is a yes and kind of answer. Where really they feed into each other. Let me pause for one moment.
Mm-hmm. Absolutely. Yeah. And so, it's really important because, we have to make sure that we are educating people about these different, changes that can be going on, right? Because education is key. And I actually had a patient who was coming in, and they were calling me. They're like, "Oh my God, Dr. Williams, I'm having a relapse. I'm getting these, periods where I'm getting a fever and I keep getting a fever." And so we kept talking and talking. And my nurse was like, "Honey, you're having hot flashes." But she literally was like, "Oh my God, I'm having a fever every day. And I don't know, I'm sick. Something's wrong. We need to test my urine." And so we kept talking. I was like, "You're having a fever every day? That doesn't make any sense." And so my nurse was like, "Ma'am, you're having a hot flash." She was like, "No." But it's like things you don't think about, because you're just living your life. And then all of a sudden it's like, "Oh, wait a minute. It's not due to my MS. This may be due to something else, and so, that education piece and that being aware is really key. When we think about age, let's talk about age. When does perimenopause usually start?
Yeah. So the final menstrual period, half of women will have gone through that final menstrual period at age 51. That means half of the women will have gone through it before and half will have gone through it after. So we know that fact. And so, and women with MS is the same. The median age is 51. But the peri starts a few years before that. It really accentuates 2 to 3 years before the final menstrual period, but it can be, sort of a bit of a moving target and sometimes subtle and sometimes not. And so I think we're at a point where we should no longer be surprised that this normal, this normal life transition happens to women. We should no longer be, sort of like, as you mentioned, sort of like, oh wait, the patients, the nurse is saying, "Hey, you're having hot flashes." We should be proactive, and we should really be counseling people starting around age 45. So some people may have earlier menopause than that, but I think if people start talking to their doctor around age 45 about this, then they can be a little bit better prepared so that they're not suffering for 3 months or 6 months with hot flashes. And as we know, people with MS do not do well with heat. With the Menopause phenomenon, when people are hot, their nerves don't work as well, and their symptoms, they think it's a relapse, but actually it's just this transient fluctuation in their symptoms. So I think starting the counseling and the conversations around age 45 so that people know to recognize things like, if you're sitting and asking people around you if they're hot too, right? That's probably a hot flash, right? So for the first time it happens to you, you're not, it's kind of incredible. You're like, why am I so hot right now? And then you put two and two together. I think if we're on the lookout at age 45, I think we can find early signs and symptoms where we can really nip these things in the bud.
Mm-hmm. Yeah, and I think it's really important. And I love how people are actually open and talking about it, and having these conversations and really normalizing conversations around perimenopause. I've even heard some celebrities, give them little nicknames like, "Oh, Perry is bothering me today. Perry gave me a hard time last night," but I think that it normalizes the experience and also makes people more open to talk about it, because it just wasn't something that I really heard people talk about growing up, so I think that part is really cool. And, again, the older you get, you really don't think of yourself as old enough, like I see like 50-year-olds that look like they're in their 20s and they're out doing all the things, and you're like, "You're having hot flashes?" Like, oh my God, like, so I think that kind of normalizes and raises a lot of awareness. So, so we're saying Go
Just
ahead.
one further thing on that note, Dr. Williams. For a long time, menopause was taboo, right? And then people
Yes.
started looking into it. But really, the reason it's normalized now, the reason we have, all these sort of online fee for service, medical, companies kind of helping women manage their period, is because we have women scientists, women doctors, women as
Mm-hmm.
empowered customers, who ask to
Yes.
be listened to. And
Yeah.
that it's taken, I think, and women funders and investors, and it's taken all of that to bring something that happens to women really to medical attention, to societal attention in a way where people get the medical care they need. So
Yeah.
I really think that we are in a moment.
Yeah. Yeah. And I love that. I always talk about, the first time I met you, we were talking about babies and breast milk and pumping, but we've learned so much and had so many advances because, women, which is the importance of having varied perspectives, right? Because there are different issues that may be important or forefront to certain people. And as scientists, as researchers, we can ask those questions and try to find the answers to questions because we understand it in a different way, or we may be focused or look at it through a slightly different lens. And so you are absolutely right that this is kind of a moment where we're talking about it, and Oprah's talking about it, all the talk shows are, it's really cool. All right, so let's talk about how menopause may specific. So we touched a little bit on how some of the symptoms overlap with MS, but how can these changes specifically affect women living with MS? We know that the majority of people living with MS are women, although our men are absolutely affected. We know that the ratio, we used to say 2-to-1, really is now more 3-to-1. In some populations, 4-to-1, women more affected than men. And so how does this affect the vast majority of those living with MS?
Yeah, that's right. As you said, 3-to-1 women to men, and 90% onset before age 50. So I think about 2/3 of all the people who get MS will be premenopausal women. And so how does it affect people? Besides those overlap symptoms that I think they really can, sometimes people can cruise by, but other people, those overlap symptoms can really wreak havoc on their life because they're just feeling worse. And it feels like it's progression, but it's not progression. And they're really worried about progression. So I think that's,
Yeah.
one way that people with MS are really specifically affected, which is, God, all these things are suddenly really worse. Now, am I going to be, asking all the questions about, am I going to progress irrevocably down the line? I think we have a junior participant on our call today. I think the second thing is people specifically talk about cognition. So people are really worried about cognition during perimenopause.
Yeah.
So the cognitive fog, the difficulty with word finding, tip of the tongue, which is a little bit the same as difficulty with word finding, but not always. The ability to sustain your attention on one task, the ability to multitask, and then having those senior moments, we call senior moments of walking into a room and thinking, why am I here? All of those cognitive changes are really real in MS and really real during the perimenopause. And so I think cognition is one area where people with MS can be really specifically affected. And so a lot of my patients ask, the second question they ask is, do I have dementia now? And it's like, no, a lot of the
It's not dementia.
actually get better. They actually stabilize. Especially if people are sleeping and not depressed or irritable. So that I think is a really specific second point. And then the third point in the way that the perimenopause affects women with MS is really something has to give. So sometimes they say this, I don't know if you hear this from people, but at this point, with the need for symptom management, with, fatigue, with life changes happening, sometimes my patients say they need something has to give. So like if I'm
Yeah.
going to have to do my rehabilitation and do my pelvic floor physical therapy, and I'm just feeling worse day by day, maybe I can't do as much. And I hear that sometimes from patients as well. So I would say that those are the things that really now Perry kind of specifically affects women with MS.
Yeah, I mean, everything, I'm seeing all of those things in clinic, right? And so the big question often becomes, particularly as our patients are getting older, how do we kind of manage these things? Is this my final destination? And so often the first thing I tell people is that, I think that some of this is related to MS, some of it's related to this, but I don't think that this is our end level of functioning, right? There are things that we can potentially do to improve. Now, will we get you back to where you were when you were 20 and staying up all night? Probably not. But are there things that we can improve from where we are? And I think that ultimately gives people hope. And I love what you said about things like sleep. This is where we really begin to work on lifestyle modification, right? So again, when you're in your 20s, you can pull those all-nighters. When we were in our training, we stayed up all night on a regular basis. I can no longer do that. Like I need sleep to be a nice person and to function, right? So if you think that someone also, if you think about it, that someone also has a chronic disease like MS, making sure that those sleep patterns, are important, making sure that we're getting a little bit of movement in, exercise, all those things are extremely important to making sure that our brain and our bodies are functioning optimally. So this is where we can really have folks lean in to lifestyle modification, and to begin to work on those things so that we can see some improvement in function. But I love exactly what you said, that there are some things we can do to improve.
And that's
Yeah.
our
So,
window of opportunity, right? So, that's our window of opportunity where again, if we're not surprised that this is happening to people, if we're not
right,
surprised that they're going to need more care, right? And
right,
and
right.
that there's a lot we can do, as you said, like, then our window of opportunity is we plan for this and we tell people,
Yeah.
I'm going to see you every 3 months, not every 6 months,
Right.
or have a nurse practice, however the practice is designed. But we're going to nip these things in the bud, and we're going to plan for healthy aging. And I tell my patients I want them to be, healthy older women. And so, we're not surprised anymore. You mentioned lifestyle. We think about, okay, what are you doing with, depending on the physical capabilities of the person, weight training, strength, flexibility, planning, fall prevention. What are you doing? What are we doing for cardiometabolic risk? Because we know that high blood pressure, can affect MS sort of like progression. What are we doing for, smoking and things like that, for wellness, for social engagement, and friends, and reaching out to other people, because we know that these are all components of healthy aging. And so if we plan to see people more frequently and to think through this more carefully, we have this wonderful window where people are like, gosh, I got to do something. And you're like, yes, you do. And there's so much we can do. We have meds, we have all kinds of meds. We also have all kinds of rehabilitation strategies and counseling strategies, right? So a lot of behavior change. So a lot we can do.
I love it. I love it. And I think ultimately it provides hope, right? And I think the other piece is that there is also an onus on us as physicians to make sure that we are aware of all of these things, right? So there was a time probably when your neurologist would say, oh, you're going through menopause? All right, go see the OBGYN. We don't have anything to do with that. There's nothing we can do. And so I love the fact that now we're working in this age of integrative medicine where, we are learning our part and counseling on our part, also sending you to, the other specialists if there are other therapies needed. But we don't just say, well, it's menopause. We don't know what to do. go see somebody else and just only talk to us about the MS when really these things are integrated and overlapping and affecting each other. So let's talk a little bit about what are some of the, maybe let's take a step back, so when we talk about the treatments for MS, that also becomes a concern with aging. Are there any interactions between MS treatment and menopausal treatment? So oftentimes my patient will call me and say, my doctor wants to put me on this. Is it going to interact with my DMT? And so let's talk a little bit about that for a few seconds.
Yeah. So in general, we haven't paid really close attention to this question. And I think some of the DMTs need liver monitoring, right? Liver safety monitoring. And some of the treatments used during the menopausal transition need, liver monitoring as well. So that's sort of, I think, the most focal area where, just sort of checking those drug interactions and thinking about, hey, maybe I was down to every 6-month liver monitoring, but yeah, maybe it needs to be more frequent based on this other medication. So that's sort of like the basic thing. In terms of the medications that we have, do we want to talk about HRT right now? Do we want to do it?
Yeah.
Okay.
Let's do it. Let's get into it.
So let's do it. So hormone replacement therapy or menopausal hormone therapy, right? So typically we're talking about estrogen, right? But then to protect the endometrium, the uterus, we add on progesterone as well. So women who've had a hysterectomy who don't have a uterus just go on estrogen. Women who also, who have a uterus need the extra progesterone. HRT really is also having its moment. And that is, we have this generational gap. A generation ago, there was this very large study, Women's Health Initiative, that really hoped to show the benefits of menopausal hormone therapy. And they gave it to women who were going through peri. They also gave it to women who were way in their post-menopause. And there was it was found to be risky because they analyzed all the women together. But when you just looked at the women who received HRT during their peri, actually those who just got the estrogen, they had lower all-cause mortality, they had lower rates of heart disease, lower rates of diabetes, lower rates of all cancers. And so HRT is now being viewed again, oh, let's revisit this topic.
Let's revisit.
Actually, it helps a lot of people feel better. So HRT during peri is given for the hot flashes, of course, but it also protects bone, and it's also associated with improved quality of life overall, bladder health as well, because the bladder health and gynecological health is also somewhat estrogen dependent. It's given for a number of things during peri. So HRT is the North American Menopause Society recommends HRT as sort of like the first line therapy for menopausal symptoms. Now, some people can't take HRT, right? And so then those people can take other treatments for their hot flashes. They can take fezolinetant or Veyoza, which is a medication just a few years old. It's very specific, just works on those hot flashes. There's also antidepressants that have been shown to work. Gabapentin has been shown to work. And then a lot of non-medication approaches as well. But for the medications, those are the main ones, and they affect the liver differently, and so that's where there may be some need for monitoring.
Yeah. And what are reasons people can't take HRT?
So the main reason people cannot take HRT is if they're at higher risk of clotting, if they have a known susceptibility to clotting, just like the oral, just like the pill, and people who have estrogen responsive cancers, so typically breast cancer. So these are situations where estrogen kind of fuels the tumor, and so people are getting anti-estrogen treatment, and they definitely cannot take HRT.
Yeah.
Um,
And I'm going to ask a sidebar. Go ahead. I'm sorry, Dr. Bove. Oh, okay. I'm going to ask a sidebar question, because I'm always curious about this, talking about coming back to things.
yeah.
So, there's a lot of research, I know like a couple decades ago where we're trying to figure out why women are more susceptible to autoimmune disease. Does it have anything to do with estrogen? Is maybe testosterone protective? I haven't seen anything recently, but have we made any advances where that's concerned? I know that also there were some studies where they were looking at some of our older injectable drugs and maybe adding estrogen along with that to see if it helped the MS at all. Have we made any more advances?
Yeah. So small advances.
I figured because I hadn't really heard any.
We know that the observational studies have real problems because they're biases. When you're just doing a study where you're just looking at how people function, do on whatever they're doing, those studies have biases because depending on how someone is doing, they may or may not take HRT or take estrogen.
Right.
So you really have to do the interventional trials, the randomized trials, where you're actually looking at placebo or control, and making sure that the groups are the same. And we have a couple trials done with a pill in women who were cycling, and it suggested very a modest beneficial effect, very modest. So one of those was just a regular sort of routine combined oral contraceptive, and the other was estriol, pregnancy hormone. In the perimenopause, postmenopause phase, we don't have trial data at this time that tell us whether the menopausal hormone therapy is beneficial specifically to women with MS. We don't have trial data at that time. There have been a few trials that look in the general population whether the HRT is beneficial for cognition, for brain, etc. And the main trial is the KEEPS trial. It's beneficial for a lot of intermediary things like heart health, things like that. But it takes a long time to see effects, and I would say the jury's still mixed on whether that trial is neuroprotective in the way we would hope it would be.
Okay. Sounds like we need to do a trial, Dr. Bove. I'm in. Okay. So our time is quickly winding up. That went by really fast. But this has been, I think, a very amazing and enlightening conversation that will really help, our viewers. So let's say we have somebody that's on the verge of peri. Let's say we've got somebody that's 45, 46, starting to feel a little cog fog, maybe some trouble sleeping. Where will we tell that person to start? So where do we start, and what are things that they can do? Because ultimately, my goal as a clinician is to treat people, but also I want people to be empowered, right? I always say there's a part you play and there's a part medicine plays. And there is no medicine that's going to get rid of the part that you play in your own health. So when we talk about people advocating for themselves, where do they start, right? They're watching all these podcasts, listening about perimenopause, menopause, and maybe having some perimenopausal symptoms. Where do they start?
Yeah. I think they start with some organization because you're right, there's so much they can do. So making appointments with their neurologist, making appointments with their internist, so that they can start putting these things on the table. I think doing the preventive screens, so those things we put off, mammogram, Cologuard, colonoscopy, all those things, getting those on the table, I think, is the next thing.
Absolutely.
And then asking that their neurologist and that their internist be familiar and comfortable handling menopause. And if they're not, asking if they can see someone who is, because there is a lot of expertise, and patients deserve that expertise.
They do.
And so asking to have someone who's up to date. And actually, a lot of these guidelines, there's a lot of guidelines available. There's a lot of nice tables that explain what to do. And so people really can ask that their clinicians look at that information a little bit. So I think that's one place where people can start. Booking those appointments every 3 to 6 months, I think, is also helpful because you're not caught as off guard with things.
Right.
And also, I think knowing that there is a big mismatch between the training of our healthcare professionals and what people are experiencing. So one example is a lot of women during peri get shoulder pain. That's all over the internet. So if you look at any online forum about peri, women say their shoulders hurt. They have shoulder injuries. If you go to PubMed, our sort of doctor research, online library, there's very little on shoulder pain and menopause, right? So that's a big mismatch. And so I also think, that tells us you got to trust your body, and you've got to trust what other people around you are experiencing, because there are gaps in training and in science. And so if people are starting to notice, changes, and they're noting them down, you are right.
Right.
And then asking your health team to kind of do due diligence and get you answers. I think that'd be my advice.
Yeah. So I love that. Regular follow-ups, right? So maybe increasing the frequency of seeing the doctor to make sure we're monitoring the symptoms correctly, make sure you're getting, the care that you need, the appropriate referrals. If you need a referral for pelvic floor physical therapy or, something else, I think that is really great advice. And then I like the piece about giving your doctor some grace, right? Recognizing that, again, even if you trained 10 years ago, this was not a conversation that we were having on a regular basis 10 years ago. So we're all learning. You are the expert on your own body, but we are learning as well. So give us a little grace and give us some time to go to a conference and learn a little bit more about menopause as well, so that we can, offer that best care. And then also there is a subspecialty even within GYN or internal medicine where people are specializing in care for menopausal women and perimenopausal women. So looking for those specialists in your area is extremely important. Well, this has been an amazing and enlightening conversation, Dr. Bove. I am sure we will have you back to either do a part 2 or talk about something else, because you are the all things women's expert in MS. So we thank you for your time. We thank you for your expertise. And I know that our Brain Chat audience is going to learn a lot from this conversation. All right. So we'll see you guys in 2 weeks. Thank you so much to the National MS Society for sponsoring Brain Chat with the Nerdy Neurologist. And we'll see you again in 2 weeks. Thank you, Dr. Bove.
Thanks, Dr. Williams.